Put 2 minutes on the clock for the first question tonight. Your time starts now. All right, time is up and let's go through to some answers. So without saying too much, a question like this is pretty common in the actual exams. It's identifying what are the barriers for Aboriginal and Torres Strait Islander people from accessing healthcare. And this is a list that you'll see again and again. So again, we'll go through next week what are the kind of common questions that seem to pop up year to year, bearing in mind there's several kind of core domains of general practice that they are always wanting to assess, and so having a good set of kind of default answers for questions like this will give you good results at the end of the day. Now, sadly, lots of things will actually get in the way of of giving Aboriginal and Torres Strait Islander people access to healthcare. First thing, of course, being services not being readily available in their area. Tied into that a little bit is the field of geographic isolation. So often there's rural or particularly remote communities where it doesn't make financial sense or viability in terms of opening services, and so there is some interplay into there. Likewise, there can be a lack of available transport, particularly as you go more and more remote. Access to public transport can be almost non-existent, and it may be quite difficult for people to access private transportation as well. In very remote communities, where there's often outreach clinics that are actually taking healthcare to these kinds of populations to try and close these gaps, so to speak. Now, of course, the world being what it is, there is high financial costs, and tied into that as well will probably be grouped together for similar reasons would be high unemployment rates in Aboriginal and Torres Strait Islander people. So any answer that's acknowledging the financial barrier that's preventing people from accessing healthcare is going to get your mark there. Tied into that, but I think would be a separate point, would be things like lower socioeconomic status, and again grouped together likely would be housing instability. And this can be not just the fact that it can be difficult to obtain housing, but in particularly rural Aboriginal and Torres Strait Islander communities, it's not uncommon for people not to have any kind of fixed home address, but rather to be living amongst several properties of relatives, friends, family, different people in their community with that kind of more shared housing mindset. Long wait times, often conflicting with the cultural expectations of different communities. Setting appointments may not work for a lot of Aboriginal and Torres Strait Islander communities, as well as a general poor availability of culturally safe or responsive health services. And that's a nice way of saying we do have a problem with racism in Australia. Anyone that's working in this country is just well aware of it. I am sure you are, and it's a sad fact that we have to acknowledge. And I think it's important to acknowledge because that's the only way we're actually going to improve things. As well, we do unfortunately have poor health literacy in a lot of these populations, which means they may not necessarily be aware, one, what's wrong, or two, that they need to seek help, three, that there is even help available. And so there are a lot of programs and packages that are actually aimed at that in particular, and that might be relevant for answers later on. Just something to follow in the back of the head. So we do have some answers here, and as Demir, you've put in wonderfully. We do have that geographical isolation tick, systemic racism. I think that's a bit more of a to-the-point way of putting in the poor previous experiences with services or culturally safe. I think you'd get those ticks there. Cultural practice not being welcomed in another tribe's area could be a little bit risky because there are some areas where that may be the case, but I think that would probably be in the minor. I would probably look for other answers on that one. Financial hardship, though, definite tick. And language barrier, yes, definitely a problem, and one that should probably be on this list as well. So very well done there. All right, okay, we have more questions coming up, of course. So let's get 2 minutes on the clock, and of course your time starts now. All right, so time is up. And again, this is another one of those common questions that you do see pop up time and time again. And so some of the important things would be to actually acknowledge the patient's opinion, and tied in with that as well, explore what their concerns actually are. So it's validating their thoughts and their feeling. Addressing fears or misconceptions, and there could be potential overlap here between some of the other answers, but I think as long as you're acknowledging that it is worth trying to express good things here, and probably the one that would overlap with the most on this one here would be to highlight examples of culturally safe and respectful care if it's from the hospital, going ahead a little bit, but still on a lot of rubrics I've seen would be counting as a point. Tied into any time where we're talking about patients making informed consent would be ensuring that they understand the potential repercussions of not attending the hospital, because sometimes people may not realise quite how unwell they are, and so letting them know, hey, look, this is actually something that's quite dangerous to be trying to manage in the community may be enough to kind of tip people over. Probably not in this case, but still would definitely be worth a mark on the exam. Now, then we start looking at, well, what are our kind of external support structures and support networks to try and tap into. And one of the important things here, of course, is with permission. You need to be obtaining consent from the patient to be discussing their healthcare to bring other people on board. So with permission, engage the patient's family. With permission, engage community elders. With permission, engaging Aboriginal hospital liaison officers. And they do have different titles depending on where you work. So anything that's kind of in that vein is going to get you the marks, but it's probably worthwhile, if you aren't familiar, find out what your local hospital terminology is, as that'll make following up referrals in the future a bit easier for you. Likewise, we've already acknowledged that transport is an issue, so actually taking that stress away from them, arranging appropriate transport, which tied in with that would be use ambulance to provide transport to the hospital. And of course, as we've already said, highlight those examples of cultural, safe and respectful care from the hospital to show that it may not be as bad as he necessarily fears. So again, to me, fantastic, involving the Aboriginal liaison officer, involving family members with patient consent. Excellent, excellent. Gold star for adding the consent line in there, as we said, vitally important. Helping organise transport, beautiful. Education on potentially lethal harms of non-attenders, beautiful. And longer appointment. You'd probably be wanting to follow that one up very, very carefully. Sadly, I don't think that last one would probably get you a mark in the exam. All right, of course, we have more questions coming up. So let's get another 2 minutes on the clock, and your time starts now. All right, time is up. And this is one of those questions that I think could muck a lot of people up. I think knowing what our billing criteria are is an important part of what we do day to day. Yeah, in reality, we're going to look it up. We're not going to try and take a punt and hope we got it right. We are going to be checking those eligibility criteria before doing anything. But for these exams, we should be displaying that we know what these kinds of criteria are in our what should be day-to-day practice. And so, of course, the criteria here is that the patient must self-identify as Aboriginal or Torres Strait Islander. And important to note, and you'll find this again and again when dealing with topics like this, it's a self-identify. There doesn't need to be any kind of evidence or family trees to go back through. The patient just has to self-identify, and that is more than sufficient. The second criteria is, of course, that the patient will have setbacks in preventing or managing their condition if they don't take the medicine. So there needs to be that element of financial hardship or inability to otherwise continue or maintain this medication without assistance. Next thing is that they are unlikely to keep up their treatment without help with the cost. So this is coming more into that maintenance side of it. And, of course, that the patient is enrolled with Medicare. True of all PBS medications, the patient needs to be in the system, so to speak, for this to go through.